Good evening, all the students present here. We'll be starting with our session.
Good
So, the
evening.
topic for today is cardiovascular, and the speaker that we have here is Dr. Varun Pushkarna, sir. He's a senior consultant at internal medicine at Fortis Escortis Hospital, Amritsar. Some more aspirants will be also joining us. Thank you. Aspirants, this
Yes,
is
sir.
going to be an interactive session. You can also unmute your mic or you can also write in the chat box. Thank you.
So this is going to be interactive. What you see on the screen is a basic scheme how to go for assessing a patient who has been given to you on the cardiovascular station. So there are a few fundamentals that you have to understand. That is, that you should not be vague in your examination. It has to be very, very structured. As long as it is structured, then you will never miss any step which is important vitally. Examiner will be impressed. That is the sole reason why you are going there for an exam, because you want to impress the examiner that I am fit to be given or qualified for MRC. So you develop a scheme of doing it and rehearse it again and again and again, so that it looks like and becomes a second nature of yours. It has to be very structured. My mantra to start cardiovascular examination is starting from the hands and ending at the feet. Okay. So whenever you reach and go closer to the patient which you have been assigned for a cardiovascular station, just look around. Look around. What is there? For example, when I had my cardiovascular stationing patient, the the patient was lying in slightly 45-degree up position. The patient was on oxygen. The patient was, having crutches by the bedside, and there was an IV cannula on the patient. So I had a very, very brief, visual inspection that the patient is likely in heart failure. Like in other examination, they will prefer keeping fit patients, but in MRCP, you can get as sick patient as you can, and the fitter patients also. So first is just wash your hands, make it a habit that you wash your hands. Introduce, I am Dr. Varun Pushkarna and I have been assigned to examine your cardiovascular system. Is it okay for you? Take permission, take consent, and look around. You can see oxygen, you can sometimes see digoxin, a strip of digoxin tablets lying by the bedside, or you can see an IABP by the bedside. You can, see these things like a furosemide infusion by the bedside. So you have a fair amount of idea what you are going to deal with. Then look for the general appearance. Is the patient, like I'm telling you, my patient was 60-degree head and up position. I could make out that the patient might be in failure because the patient was on oxygen and the patient was tachypneic. So you have to look for any cyanosis and distress just by going there, and be very careful. These patients, if they have an IV cannula on them, to touch them with utmost care and respect that the cannula doesn't hurt, because these patients are already on cannula and sometimes thrombophlebitis is there. So the moment you hold their hands, even for a pulse examination, they might wince with pain. If they do, ask for forgiveness. Say, I'm sorry, I did not intend to hurt you, but if it has hurt you, I'm sorry. I'll prefer doing it in a calmer way. Please, I'm sorry. Look for the scars. These cardiovascular patients may have CABG, and all scars in the midline, they do not necessarily mean that the patient has had a CABG. It only means that the patient has an open heart surgery, which could be CABG, which could be a valve replacement, which could be in older times ASD, VSD closure, which could be a TOF or any congenital heart disease repair. surgeries. So you need to know that every scar is not a CABG scar. I mean, every mid-sternotomy scar is not a CABG scar. You should keep everything in mind. One patient I had in real life, one patient I had a mid-sternotomy scar, and I generally thought that the patient was young. He was just what, 34 years. He was a doctor. So I asked him, "Were you taken up for CABG?" So he says, "No. I met with a car accident, and in that car accident, few ribs they broke and they entered into my mediastinum and they caused a concealed cardiac rupture. So I was operated upon and my ventricle was sutured. That was, fortunately for him, it was the right ventricle. So imagine if we just look at a sternotomy scar and somebody, we assume that the patient might have had a CABG. So don't commit to that. Tell to the examiner that there is a mid-sternotomy scar. It is for the examiner to ask you, what does it signify? You just have to say that the patient has had a history. It looks like that the patient has had a open heart surgery. That could have been for bypass grafting. That could have been for a valvular repair or replacement. That could have been for, sometimes it is just for pericardiectomy. So these are the surgeries which can be accessed by opening up the sternum. Is that clear? Is that clear?
Yes, sir.
Great. So, as I told you, that my personal scheme of assessing the patient starts from the hand. I will try to draw a picture here. So, if the patient is lying on the bedside and you see the patient from this end, so
एक बार बोल के रखा है उसको, अभी बोलने के बाद में नहीं करना है, like
okay, if the patient is like this, so you start with the hands. You hold the hands gently in your hands and examine for any clubbing, examine for any peripheral cyanosis, examine for any splinter hemorrhages, examine for any palmar erythema, examine for any clubbing, examine for any needle prick marks, because sugar, some patients are diabetic, so sugar testing marks. So you look at them and then you turn the patient's dorsal side and see for any IV drip or any marks there. And then you go to the wrist. In the wrist, you check for number 1, radial pulse. And the moment you check radial pulse, always check on both sides together. So radial comparison. Always do. So you're still at the hand, okay? So check for any radial delay or any needle marks that will tell you about ABGs being taken, okay? Then you move up and go here. Sometimes you can even see a radial harvest. What is a radial harvest? Anyone? What is a radial harvest?
So for dialysis, they use.
So that is a AV fistula formation. That is not a radial harvest. So radial harvest is seen in patients who are taken up for young CABG patients. So what happens is they take a radial artery to be put on, because if you have any idea about CABG, I will just draw a diagram for your convenience. So this is heart, this is aorta. So when they put in new coronaries, the Lima to LAD graft is taken. Lima is left internal memory artery. So Lima is grafted always on the LAD territory. Okay. But what about the RCA and the circumflex? usually they are put like a venous graft. But in young people, good surgeons, they try to take a radial graft. So they put in a radial graft. So that is a radial harvest. You harvest the radial artery from here, and then you put it one end into the aorta and other end into the RCA or circumflex. Is that clear? Radial harvest. So alongside, you of course can check for AV fistula. You rightly said that. And here you check for the water hammer pulse. Water hammer pulse. Water hammer pulse is that you place one hand of your, so you place one hand here and one hand here. So basically you lift the arm upwards, and with the hand that is present here, you feel for the tapping of the pulses. Like this is the hand and you lifted it. So what will happen is you block the radial here and you just keep a soft hand here at the elbow. The pressure will come down, and if it completely comes down, that it becomes a water hammer pulse. In which condition do you see water hammer pulse? So you see that in aortic regurgitation. Okay. So once you move from the fingers to wrist to elbow, then you move right to the neck, directly to the neck. Of course, you can palpate for axillary, or you can check blood pressure here on the forearm. But usually you are not required to check the blood pressure. You can tell it later that I would also want to check for the blood pressure and pulse oximetry of this patient. Okay. All right. So here you check for two things. One is visibly see for any carotid pulsations in the neck, and also look for any JVP. Now, if the JVP has to be checked at 45 degrees angle, and also once you see the JVP, the study is not complete until you press on the liver. So that is called hepatojugular reflux. So always ask if the patient has any pain in the abdomen. If it is there, tell them that I'm going to press on your abdomen. Please bear with me. And if there is pain, let me know so that I can stop my examination. So you press on the abdomen and you see for the JVP to rise. That is a positive hepatojugular reflux. What is the significance? It can diagnose occult heart failure patients who are diurized and not in obvious heart failure. But when you press upon the liver, the JVP goes up. That can tell you about the this thing, about the
Heart failure.
Heart failure. Okay. Then from jugular, you go up to the lips. So in the lips and in the eyes. So you look for any pallor, you look for any jaundice, you look for any telangiectasia on the face. In which condition do you see telangiectasia on the face? Scleroderma. Okay. Scleroderma. Because these patients can also be there in the cardiovascular station because of resistant hypertension, because of scleroderma can produce hypertension. Okay. So, and you see the oral cavity for central cyanosis. Okay. From here, now you come down and look at the chest. In the chest, you look for any, in thin people, you look for any apex beat. If you can't see, turn the patient towards yourself and try to focus if you can see an apex beat. So you've seen the apex beat, or if you've not seen the apex beat, but just look at any mid-sternotomy scar, any lateral scar. If the, let me erase this photo. So now that we are on the chest part, so in the chest, what you look for is, number one, you look for the apex beat, you look for any mid-sternotomy scar, you look for any chest tube scars, which are usually 1, 2, 3 in number. So left side chest tube, central pericardial chest tube, and the right sided rarely, but these are the main ones. And sometimes you see a mid-cap scar. Mid-cap scar is minimally invasive CABG. So that is done only for Lima to LAD. So there is a midline scar, not a midline, but a left-sided scar, horizontal scar. So that is what you see. So once you see the apex beat and any scars or anything, then you need to press your hand on the apex beat. I always tell my students, never ever auscultate directly. It gives you negative marks. So wherever you see an apex beat, palpate it. So first you see, then you palpate it, and where you palpate it, only then keep a stetho there. Why do you not keep a stetho directly? Because you cannot see apex beat in every patient. So you'll have to feel it, and then once you know where the apex beat is, then you keep your stetho. Why? Because it is from the apex beat upwards that you do your cardiovascular examination. Is that okay? So do not put your stethoscope directly on the apex. Then you go to mitral area, then you go to tricuspid area, then you go to aortic area, then you go to pulmonary area. Initially, you feel all of them with your hands, the apex beat first, then the thrills, the heaves, and the thrills. So the heave is present on the, so this is the sternum, these are the ribs. So parasternal heave is felt on the left side of the sternal border and right side of the sternal border with the ulnar border of your hand. It's like karate, like we do karate. That is how you keep your finger, keep your hand. So once you have them, then you place your palm, the heel of your the eminence that you see on the palm of the hand. So that you keep on these areas, and then you feel for the pressure thrill coming from underneath. Is that okay? Also, you see pacemaker scar there. So this is the, so here you see a pacemaker scar, usually like a pocket of the shirt. Is that clear till now? Yes.
Sir, for apex beat, so you said the patient should be lying on flat, then the patient should be shifted to the side of the examiner, yeah, opposite side of the examiner to feel it better.
See, you can do that either way. It is usually away from yourself, but you can turn the patient towards yourself also. So away from yourself, the heart will fall on your hand and you will feel it better. But sometimes when it is a left ventricular hypertrophy, the heart would have gone even laterally. So you will need to turn the patient towards yourself.
Okay, sir. Okay, sir.
Because usually they will have patients, from the cardiology. So they might have left ventricular hypertrophy, and we all know that whenever hypertrophy happens, the heart goes leftwards. Okay.
Okay, sir.
So this is just the sum up. In the hands, you feel for temperature, radial pulse. You check for rate, rhythm, and collapsing pulse. Collapsing is at the brachial. So rate, rhythm, you usually palpate the finger, what do you call that? You palpate the pulse with the, how many fingers do you do that? You do that with 3 fingers.
3 fingers.
Okay? Yeah. All right. Okay. Yeah. All right. So once you have checked for the palpation and you auscultated the valve areas and the what do you call that, murmurs, then you of course focus on the mitral and tricuspid area for the murmurs. Just a second. Then you move down to the abdomen. Now your upper end is complete. So this is the last ribs, and this is the abdomen of the patient. So look for any hepatomegaly, look for any ascites. So in the ascites, you feel for the fluid thrill. Then in the legs, you look for vein harvest scars. Again, CABG patients. So great saphenous vein is harvested and put on the graphs that I just told you. Then look for, many times students ask me, sir, what about radiofemoral delay? What about femoral delay? So it is never a bad idea to do that, but because the time constraint is so much, it is best to go for dorsalis pedis. Why? What does dorsalis pedis tell you? Number one, if you can feel the dorsalis pedis, let us say, if you feel the dorsalis pedis here, where do you feel the dorsalis pedis? It is between the first and second metatarsal space. So that is where you feel for it. If dorsalis is there, that means the leg circulation is reaching here. Okay. That means femoral is fine. That means popliteal is fine. Only then it reaches the dorsalis, right? So you can feel for dorsalis and of course posterior tibial if you are very, very cautious, if you have time. And then when you look for the dorsalis pedis, do that on the other side also, because it can tell you about, number one, incompetence of the arteries. Second, it can tell you about any patient who had a aortic aneurysm or aortic plaque or even aortic dissection. So rarely they can have such a patient, or they may ask you this question because they obviously will not have a dissection patient in your examination. But peripheral pulses are important. So radial 1, radial both, then dorsalis pedis 1 and dorsalis pedis both. You can check for delays and all. And once you've done, this is the moment when you check for, this is the moment that you check for pedal edema. Okay, this is the time. But before that, I missed out on something. Sorry, my bad. When you were there on the chest, no, when you were auscultating for everything in the heart, that is the time you go back. That is at the back of the patient. You auscultate both the bases of the chest. Number one. Number two, auscultate between the scapular blades. Why? Anyone? So coarctation of aorta, you can best auscultate at the back of the patient between the shoulder blades. Is that clear? Yes?
Yes, sir.
So, and at the same time, when you are doing that, press on the sacrum to look for any sacral edema. So that happens in the chest examination only. So, and now after checking the pedal edema, thank you the patient, summarize the findings and prepare for your discussion, including diagnosis, differential investigations. So if I have to summarize, kindly listen to me now very carefully. Wash your hands. While washing, look around, look for any things, greet the patient, tell them I am Dr. So-and-so and I am asked to examine you today. Then hold the hands of the patient gently, look at the nails, look at the clubbing, look at the splinter hemorrhages, look at the osseous nodes, look at the any needle pricks, look at the palmar erythema, look for any IV marks on the dorsal of the hand, then look for the temperature also. Then move to the radial artery. Once in the radial artery, if you are very meticulous and you have practiced very fast, you can always check for Allen's test also. What is an Allen's test? So Allen's test is to check for the
Patency of radial artery.
No, it is done for the patency of dorsal arch. So you press for the radial artery and you wait for the ulnar artery to take over. Because there are two arteries in the hand. Sometimes when you press the radial artery, what happens is there is no flow in the dorsal arch of the hand because the ulnar artery is insufficient. So it is to check the ulnar artery, not the radial artery. Radial you press. So do the Allens. Once you look for the radial artery, go for both the hands, both the radial, look for radial delay, and look for any missing radial arteries. So where do you look for missing radial arteries? In Takayasu arthritis, in atherosclerotic disease, and in congenital coarctation of aorta. So these are the problems that where radial problems can be there. From radial artery, you move upwards to the brachial artery. Brachial artery you feel and then you check for water hammer pulse. Then you go up, measure the blood pressure. Obviously, you don't have to, but you have to tell them. Then you move up to the shoulder, and from the shoulder, you reach the neck. In the neck, you look for JVP, look for carotid pulsations. And if you are keen enough, put a stethoscope there, tell the patient not to breathe, and auscultate for any carotid bruit. Still go up, and up you go, and you look for pallor, you look for jaundice or icterus, and then you look for the lips and look for the cyanosis, central cyanosis on the tongue, and then you come downwards, and in the downwards you look for any apex beat, and if you see the apex beat, then you palpate the apex beat. Once you've palpated, go for the pressure system signs like heave, paraventricular heave. Then look for any what do you call that, thrills. Both palms of your hands, both sides of the sternum, feel for the thrills. Then once you have felt them, go for the stethoscope. Where did you feel the apex beat? Put the stetho there, listen, that is the apex, move upwards for mitral area, tricuspid, aortic, and pulmonary in that order. And also under the left clavicle to look for any pinwheel murmur in case of patent ductus arteriosus. And then spend some time on the mitral area and aortic area. These are the places where you will potentially hear any murmurs if the patient may have one. And then you always keep looking for any scars during that time. You can mix and match. Look for sternotomy, look for chest tubes, look for pacemaker, look for any left costal scar for any patient who might have had a lobectomy or maybe mid-cap surgery. Then you take the stetho to the back side of the patient, auscultate the bases of the chest and interscapular area. Then you turn the patient and make them lie down again and look for abdomen. Bend down to your feet level to see if there is any hepatomegaly which is visible from outside. If not, then of course you can, if you had missed checking the hepatojugular reflux earlier, now is the time you do it. Also check for ascites. Look for any marks in the abdomen. Then you go down, check for femoral pulses, then go down to dorsalis. Dorsalis, you have to compare both. Femoral, you have to compare both. Femoral, you can compare with radial also. And then check for any pedal edema. And then wash the hands again and thank you the patient. Is that okay? That is the scheme. All right. Any questions there? No? Fine. So you, in the cardiovascular station, you are not supposed to ask any questions because it is just an examination. So you will get very, very famous cases like aortic stenosis. Usually aortic stenosis are elderly people, and look for the bedside ticket. There may be written syncope. So you will get a hint, or dyspnea. So there will be pulses, parvus et tardus. That is a slow rising pulse and a slow pulse. Slow rising pulse. On auscultation, you will find an ejection systolic murmur in the aortic area and heaving type of apex beat. Of course, if the examiner asks you, then valve replacement it is. And in aortic stenosis, the ejection systolic murmur can be auscultated in the carotid also. So whenever you put a stetho on the carotid, always hold the pulse of the patient. Why? Because that is how you would know that this is a systolic ejection murmur. Is that clear?
Yes, sir.
Yes. Then another important case is the mitral regurgitation. So in mitral regurgitation or even MS, it is usually a female with mitral phases. Patient will have a displaced apex. So that is when you might have to turn the patient towards yourself. So the apex beat will be displaced. And when you put the stetho on the mitral area, there will be a loud murmur, pansystolic. Be prepared that whether it is a VSD murmur or it is a mitral regurgitation murmur. Mitral regurgitation is a beautiful musical murmur, whereas the VSD murmur is a cooing type of a little harsher murmur, no musical. And those patients, because what is mitral regurgitation in young females is usually secondary to rheumatic heart disease. So they might have pulmonary hypertension, a pulmonary right-sided heave, and a thrill on the pulmonary area, and atrial fibrillation. All these signs will be present. P2 will be delayed. Why P2 will be delayed? Because of pulmonary hypertension. And management, of course, is the Viva thing. You will need to read about it. Okay. Then third type of patients that are usually kept are post-CABG patients coming for routine checkup. So they will have a sternotomy scar, a radial harvest. You see here radial harvest? So radial scar or leg scars is venous harvest. Then look for the signs of heart failure. What are the signs of heart failure? In a patient when you are, say again?
Pedal
You started the examination with hands and you are saying pedal edema.
Sorry, sir. Sorry, sir.
You start with the hand and tell me everything about heart failure. What will be there in the hands? So the patient may be having clubbing because of chronic hypoxia secondary to heart failure. Number one. Usse bhi pehle, the patient might be lying in a head and up position. Okay. So number one is look for the hands, look for any, clubbing, cyanosis, and the patient will have tachycardia. Why does the patient of heart failure have tachycardia? Because whenever the heart fails, gradually the left ventricular end diastolic volume expands. Body releases epinephrine to increase the heart rate. Why? Because cardiac output is heart rate into stroke volume. These patients of heart failure, they have lower stroke volume, and the heart only knows to increase the heart rate so that stroke volume may remain same, but as the heart rate increases, cardiac output will increase. But it will not only increase the heart rate, it will also increase the systemic vascular resistance. So these patients may be cold and clammy or cold and wet when you feel them. Okay. So cyanosed, cold, these patients are of heart failure. So then you check for the tachycardia and weak pulse. So there will be tachycardia, heart rate will be more than 100. It will be weak pulse, you go up. You see the signs of elevated JVP. You see hepatojugular reflux increased. Then apex beat will be, sometimes it is visible. Patient is obviously tachypneic. You put a stetho there, you auscultate, you might find a murmur of mitral regurgitation, bilateral crepitations in the chest, and a positive hepatojugular reflux. Some of these patients may have a palpable liver and ascites, and then a pedal edema along with the sacral edema. This is how you say signs of heart failure. Is that okay?
Yes, sir.
They may have central pallor or central, cyanosis. All of these features, these are signs that you have to. This is why this exam is for, so that you don't jump to a conclusion. You do it in a systematic way and explain also in a systematic way so that you don't miss anything. So be systematic in your findings always. All right. So what about mitral stenosis? I purposely missed out that patient. What about mitral stenosis? So in mitral stenosis, when you see such a patient, what will you see? These are very important points. So the pulse will be low volume. Why low volume? Because mitral stenosis is a fixed cardiac output state. The heart cannot increase the cardiac output. It's a fixed stroke volume. Why? Because the opening from the left atrium to the left ventricle is a restricted one. It cannot open. So if it can let us say 50 ml of volume, only 50 ml will go. So the heart rate will be dependent again. So the cardiac output will be dependent upon stroke volume into heart rate. So these patients will have increased heart rate, but because of decreased stroke volume, they will have a poor pulse, weak pulse. Okay. So low volume, regular or irregular pulse. Why irregular? Because mitral stenosis patients usually have atrial fibrillation. Okay. So there will be no radial delay, no radiofemoral delay. All the peripheral pulses will be palpable because of a tachycardiac situation, and BP will be low, usually 90/50, 80/60. This is the blood pressure. Apex beat will be normal in position. What will be the character of the apex beat? Anyone? Anyone? Apex beat in mitral stenosis. This is the most important patient that will be kept in Indian scenario exam. So apex beat will be tapping in nature. Okay, that is the importance of keeping your palm on the apex beat. Is that okay?
Yes, sir.
There will be diastolic thrill. There will be a diastolic thrill. And how do you check for diastolic thrill? It is best palpated in the left lateral position and at the peak of expiration. You tell the patient to breathe out, and at the end of the breathing, you will feel that the patient has a diastolic thrill on the mitral area. Is that okay? Even the S1 is palpable. It is a beautiful viva in PACES when mitral stenosis is kept. Why? Because of multiple signs and everybody is interested. Only in India, Pakistan, Nepal, Sri Lanka, Bangladesh, do you see rheumatic fever patients still there. In UK, you will not find any. So they are also excited, the examiners. Oh, rheumatic fever rakha hua hai. Oh, mitral stenosis is also there. So S1 is loud. S1 is loud and snapping. So there will be opening snap sometimes. Okay. And when does opening snap come? This is a usual question. When does opening snap come? It comes after S2. Why? Because it comes before S1. Is that okay? So unless you are very expert, auscultating a diastolic murmur with the bell of the stethoscope is a very difficult task because it's a diastolic murmur. And if these patients have tachycardia, you may not auscultate at all because it doesn't give you much time for auscultation. And if the patient has pulmonary hypertension, always listen to and feel for the pulmonary thrill. Usually the apical impulse in these established mitral stenosis is, this is a very good question, that apical impulse in a established mitral stenosis patient is usually by the right ventricle. Why? Because it is a displaced heart. Now it has displaced towards the lateral side, and it is the right ventricle which has come to occupy there. So there will be a diastolic thrill at the apex. As I told you, best palpated at the left lateral position, and there is a left parasternal heave as a result of pulmonary hypertension because of RV hypertrophy. Is that okay about the mitral stenosis? Anyone? Any question? So these are the basic questions that you will be asked in the exam, and then be prepared for everything like Corrigan sign.
Regarding this mitral stenosis, murmur,
Yes.
we will have pre-systolic association.
Say again. I couldn't hear you properly. What did you say?
Sir, in case of murmur of mitral stenosis, when you will get a pre-systolic sensation and when you will not get a pre-systolic sensation first, and how do you identify pre-systolic sensation? Murmur, basically.
There is a problem. I couldn't hear anything.
Sir, how do you identify pre-systolic sensation in mitral stenosis?
Okay. So you just asked that pre-systolic accentuation. That is, you need to define it first. So what is pre-systolic accentuation? So pre-systolic accentuation is the murmur just becomes loud before S1. And it can only happen whenever there is an atrial kick. You remember cardiac cycle? In cardiac cycle, while the ventricular filling is on, that is, ventricular diastole as we call that, at the end of this phase, there is a small phase that is called atrial kick or the atrial systole. Is that okay? So, pre-systolic accentuation is due to atrial kick. And always remember, if the patient has a sinus rhythm, only then atrial systole will be there, or as you call it, pre-systolic accentuation will be there. If the patient is in atrial fibrillation, there will be no atrial systole, there will be no atrial kick, and there will be no pre-systolic accentuation. So, as you asked, pre-systolic accentuation will be there if the patient of MS is in sinus rhythm. But if the patient is not in sinus rhythm, patient is in atrial fibrillation or flutter, you will never get a pre-systolic accentuation. Is that okay? Yes? Or whenever there is a very severe mitral stenosis, so severe that even an atrial kick cannot get the blood to flow more, or extra flow cannot be generated, then it is a calcific, immobile, patched up valve. That means there is no blood flow, significant blood flow happening, or when the left ventricle has failed. What will happen in a left ventricle failed situation? Let me draw it for you. So what will happen is, if the LV has dilated so much that it is, finding hard to pump, Starling's forces have failed. So there is the atria. It is trying to pump blood into an already filled ventricle. So in that case, again, pre-systolic accentuation will not be there. So there are 4 situations where pre-systolic accentuation is not there. Number 1, when the patient has atrial fibrillation or flutter. Number 2, when there is a very severe MS. Number 3, when it is a calcified valve, completely calcified, or when the left ventricle has failed. So if you hear a pre-systolic accentuation, that tells you that the patient is in sinus rhythm. Okay? Yes? Yes? All right, doctors. This was a PACES session for the cardiovascular station. All right. So I will take your leave now. Thank you very much for your patient listening.
Thank you, sir. Thank you, all the aspirants present here. We'll be having the next session in next week, and we'll be keeping you informed. Thank you, sir.
Sir,
Thank you.
which book do you recommend for preparations for the clinical vivas?
There is a nice book. There is an Indian book also, S. Das, probably you can read.
Okay, sir.
It's a good book. Then there
What
is a
about, sir?
Kundu.
Okay, so for PACES, what will be the international book we'll see for?
There is one book that I used to read back, in 2015. I don't remember, but it is called Long Cases for PACES.
Okay, sir. Okay, sir.
Long Cases for PACES. I'll find out that book and I'll share it with Sana. And I think I would have a soft copy of it. And in case you would
Yes,
need
sir.
it, you can get it printed. Okay?
Okay. Please, sir. Okay, sir. Thank you, sir.
Okay. Bye-bye, everyone.
Thank you, everyone. Thank you, sir.